Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, I would like to thank the DAR Alliance for giving me the opportunity to be here today. And a special thanks go to Professor Muhammad for this rich program in the first and the second day, and I hope you all enjoyed it. So the famous picture, moving from the insulin therapy into a very long road till we reach into moving from the isolation of insulin, from a bovine insulin into the second generation basal and bolus and ultra-fast insulin. And it's not just about the types of insulin, but about the revolution in the management of the presence of insulin delivery systems, as well as the blood glucose monitors. And then the sensors are tangled with the insulin pump to reach into the presence of the artificial pancreas. We are all aiming for the cure, whether technological or immunological cure, but the main thing is to have the best quality of life with no complications in those patients. As we all, that Muslims are increasing worldwide in numbers. And definitely, we have talked for the past 2 days about the risk of Ramadan fasting. But we're moving beyond the hypo and hyperglycemia, as well as dehydration, into a more important thing, which is the glycemic variability and its relation to both macro, as well as hypoglycemia incidence. And that's why various organizations have developed guidelines to ensure safe fasting for type 1 diabetes, whatever the age. We're talking about adult population as well as adolescent. And definitely the DAR was among the first organization to do those guidelines. My main focus here is the closed loop and how it accommodates with the international guidelines of the CGM metrics, and how these systems internationally are now integrated into the global guidelines for treating type 1 diabetes. So just a glimpse about those closed loop systems, that though they're having the increase of the basal insulin whenever the blood glucose is trending high. And definitely it will lowers down the basal insulin if the blood glucose is trending down. So it's not just the automatic basal adjustment, but as well as the autocorrection if the maximal O2 basal is reached, as well as the sensor glucose is above 120 milligram. And you can see here the violet shape where you can have the autocorrection automatically bringing down the trending high blood glucose in those systems. It's not just the O2 basal and autocorrection, but adding to it the safety module that is present in the automated hybrid closed loop. So you can adjust the bolus if the algorithm detects that trending down of the blood glucose. Moreover, it has an automatic upload of the CareLink profile, as well as a smartphone connection, and you have a connection with your healthcare provider, as well as patients and their healthcare givers. Those are the most common hybrid closed-loop system now present worldwide. Majority are present in our region. But you can see different studies, more than 10,000 patients internationally having those hybrid closed loop with very good evidence of safety and effectiveness internationally. But it's not just internationally. Even for our region, you can see the real-world evidence from user for that. So the friendly reminder about technology, the open loop system. So you have to avoid the hypoglycemia by making adjustment of the basal insulin, decreasing the basal insulin during the fasting hours, and in order to mitigate hyperglycemia, you have to increase the basal insulin. And those are one of the first publications on how to adjust open loop systems during Ramadan fasting. So moving from the low glucose suspend into the predictive low glucose suspend, and again, you can see more than 2 hours of suspension in order to avoid hypoglycemia. So it's not just during the fasting hours, but even during the non-fasting hours, we're going to have hyperglycemia during the iftar, and as elegantly presented by Professor Salma Mihar yesterday about the difference in the high glycemic index carb and the protein and fat content in the iftar meal where we have hyperglycemia. So those patients might use the square and dual boluses, as well as they're doing taraweeh or prayers or exercise, they can use the temp basal. But again, you can see from the region, one of them, Professor Reem Al-Amoudi, comparing the insulin pump with the multiple daily injections. So till now, even the open loop helps in conduct safe fasting. One of the publication looking at the difference between basal insulin adjustment versus those with intervention, we're having a temporary basal rate as well as extended bolus. And this comes to account of decreasing hyperglycemia seen during the iftar meal. Moreover, an Egyptian patient living in Italy using the predictive low glucose suspend algorithm was successfully made to conduct safe fasting through this algorithm, as well as from Qatar, Professor Graham Petrovsky, looking at the standard hyperclosed loop and again maintaining the time and range while fasting. Moving from the open loop system and looking into the closed loop, and international guidelines looking for those closed loop systems regarding pregnancy, exercise, as well as sick day management. But let me add another special situation, which is Ramadan fasting. We've got more and more clinical evidence and trials from the region about safe fasting during Ramadan. Until now, we've got 6 studies. I'm not going through all of them, but I'm just giving you a glimpse on that. So the first thing to go into the pre-Ramadan education, the person and the patient must look into their responsibility, doing the sensor calibration, looking into the curling software, doing the appropriate bolus timing, as well as responding to alerts and alarm and the catheter. And for the healthcare providers, they have to look for the different curling reports coming with the advised hyperclosed loop system. With the Ramadan period, they can be followed up during the either clinically or virtually in order to reevaluate the time and range settings. So let me go through the Ramadan studies in clinical trial about the hybrid closed loop, and I'm proud to say that this is the first worldwide study that was published about the advanced hyperclosed loop and fasting in Ramadan with a randomized clinical trial, looking at adolescent and young adults who were included in the study, those with micro and macrovascular complications or hypoglycemic unawareness or recurrent DKA were excluded. And then we've done the randomization of the patients, looking at the control group, those with optimal insulin pump settings, having an active insulin time of 2 hours and a blood glucose target of 100, versus the conventional or the less aggressive insulin settings, having active insulin time of 3 hours and a target blood glucose of 120. Again, remember that you have the feasibility to act and make the temp target active to 150 milligram if the patient needs to have less hypoglycemia during the fasting hours. The primary outcome was looking into the time and range from baseline and the end of the trial. The secondary outcome looking at the time above and below range, as well as the safety outcome, the major concern of occurrence of hypoglycemia, as well as DKA. So we have included 42 patients, mean age 16 years of age. And I'm going to break this table looking at the average sensor glucose in those with aggressive or optimal pump settings with better outcome versus those with conservative settings. And definitely this was reflected on the GMI. And the most important thing, looking at the coefficient of variation, where you have the ideal coefficient of variation, which is usually not seen when you're looking into the sensor tracing of those patients. Again, more green in the time and ranges downloads. So those with better or aggressive settings can have the optimized and the time and range settings looking into the glucometrics recommended by international guidelines. Again, with the presence of the O2 basal and O2 correction, this was reflected with increase of the total daily dose as well as the O2 basal and O2 correction. And the most important thing, sometimes the healthcare providers, they don't have to change the settings. They can keep the same as pre-Ramadan. But what we have to do is to make the insulin to carb ratio more aggressive. Sometimes we have to increase it by 30 to 40% in order to mitigate post-iftar hyperglycemia as seen in both groups. And again, remember the degree of engagement of the patient with the system, the sensor adherence, the O2 mode less exit on those patients will give a better outcome. And again, no breaking of the fast, either between the control group or the intervention group. So the outcomes were met, the time and range above and below, as well as the safety outcomes with zero severe hypoglycemia, diabetic ketoacidosis, or hospital admissions. And you can see the whole publication if you need to read the first publication about 780G and insulin pump. Other studies coming from Saudi Arabia, Dr. Wanis looked into the standard and advanced hyper-closed loop, and they've got 11 patients coming either on the 670G or the 780G. And again, looking during and before Ramadan, again, you can see the same ratio, non-significant in the green color, either those who have fasted versus no fasting group. So we have maintained the same thing. But the O2 mood, the engagement in the 780G was more prominent than in the standard hyper-closed loop with O2, with no O2 correction. And the Dr. Wanis also has published a case report of an 11-year-old child who have compared the year when he was in an open loop and the consecutive year when he was on the hybrid closed loop, the blue versus the gray color. And again, you can see the optimal setting with the average blood glucose was much better using the advanced hyper-closed loop versus the standard or the open closed loop with the 640G, as well as the total daily insulin and the bolus amount. And you can see here the time and range was less using the predictive low glucose suspend pump versus the advanced hyper-closed loop. Gulf clinical trial was seen recently, has just been shown, and I'm just going to give you a glimpse about the time and range, the overall between the daytime and the nighttime, and the distribution between the bolus autocorrection and a basal, as well as the adaptation of the system before, during, and after the month of Ramadan. I'm not going to go into details, but please stay tuned to the lecture of my dear brother, Dr. Mohammed Al-Sufyani. He will give you more and more updates about his studies and more enthusiastic news about Ramadan studies and the advanced hyper-closed loop. So, in conclusion, technology is a game changer. The patient has to be motivated to be in the smart guard, and achieving the optimal glycemic parameters can be safely done even in the most aggressive settings without compromising the time below range or hypoglycemia. And this will give more aid to the healthcare professionals, to individuals planning to fast during Ramadan, which was not present using the multiple daily injection or open loop insulin pump, where we have to do many basal bolus adjustment as well as changes in the carb counting. And then you can use the temp target, you've got the safe mode, and you can make the ICR more aggressive. And despite the risk of fasting in patients with type 1, the real-world evidence shows that the advanced hyperclosed loop showed similar time and range below and above range if you're comparing before, during, or even after Ramadan. However, disparities for each race, gender, is present to make those hybrid closed-loop systems and sensors available worldwide. They have proved superiority, effectiveness, as well as safety. And I hope that we can find worldwide those advanced hyperclosed systems that can make the substantial changes that occur in the lifestyle of people with type 1, not only during Ramadan fasting, but throughout the year. At the end, I would like to thank all people living with diabetes, people on the advanced hyperclosed system, the diabetes team following them up, and the supporting team for the healthcare providers and users. Thank you so much.